So next, talking about heart failure, we're going to quickly take a look at the path overview real quick. So one of the big things we need to think about with heart failure is this is really a problem with producing adequate cardiac output, which can lead to increased peripheral vascular resistance. So problems with cardiac output, we're talking about like final ejection fraction. So like how much force is produced in basically the aorta, after the left ventricle. So when patients are not able to produce adequate cardiac output, then they've developed heart failure. And that leads to an increase in peripheral vascular resistance because on the other side of that kind of closed plumbing, the fluid is going to back up because the heart, can't keep up with the amount of fluid that's going into the patient. So one of the big ways we want to start thinking about heart failure is that these are often problems of volume overload. So patients are going to present with very similar symptoms to a volume overload patient. And a lot of our management of heart failure is really management of fluid volume overload. So in case you guys like the cartoons, here's our two cartoons for the symptoms. And to point out that we have right-sided heart failure and left-sided heart failure. And the reason it's important to differentiate these two is the symptom presentation of a patient who has left versus right-sided heart failure is a very different type of problem. They're going to have very different symptoms associated with right-sided versus left-sided heart failure. So speaking of assessment, when we get into our kind of recognizing cues on our patients, on right-sided heart failure, we're really looking at circulatory symptoms and GI as well, but the reason is because of circulatory symptoms. So the specific things are like peripheral edema. Sometimes there can be a right-sided greater than left-sided edema, but we are going to start seeing peripheral edema. Because this is problem of fluid volume overload, it's going to be pushing fluid out of the vascular space into the interstitial space, leading to the edema accumulation in the lower extremities. That doesn't mean that the vascular system is then okay. There's still an excess of fluid volume in circulation. So we can see things like JVD as well in the neck because they're going to have too much fluid volume in the circulatory system for the heart to adequately maintain normal circulation. This can lead to symptoms of orthostasis because patients are going to have labile blood pressures. They can either be hypertensive, hypotensive, depending on the amount of damage that's been done to their heart by how long they've had heart failure or how fluid volume overloaded their circulatory system is. So we always want to look out for patients complaining of like orthostatic type symptoms. For right-sided heart failure, while we're dealing with these circulatory problems, the GI system is also another big one because we get fluid backing up or blood backing up in the vessels in the abdomen as well. This can lead to some severe discomfort, and patients usually experience this as like nausea and vomiting. So that's always something that we want to look out for right-sided heart failure. When we switch over to left-sided heart failure, then fluid is backing up in the circulatory system starting at the left side. So on the right side, fluid is backing up into the circulatory system. That's where we see most of our symptoms. On the right side, on the right side, it's circulatory system. On the left side, fluid is backing up into the lungs. So most of the symptoms we're going to see with left-sided heart failure are actually pulmonary symptoms. So these patients are going to have pulmonary edema. Just like right-sided has peripheral edema, left-sided has pulmonary edema. So patients are going to have shortness of breath, cough. They may or may not have like slight blood tinged or hemoptysis kind of coughing. It's not uncommon. It does happen, especially if they start to have fluid accumulating into the lungs. So that real edematous fluid backup in the lungs. These patients can also have hypoxia, so that's something we want to look out for as well. They also have all the symptoms of right-sided heart failure because that fluid doesn't just back up in the space between the right and left side of the heart, it continues to back up through the right side of the heart and into distal circulation. So we will see all the symptoms of right-sided as well as these extra respiratory symptoms for left-sided heart failure. When you talk about prioritizing hypotheses, so on the physician side, it's kind of a complicated picture. There's a lot that goes on the physician side for managing heart failure and identifying heart failure. So first comes screening. A lot of the data and diagnostic for heart failure comes from physical exam. So they're looking for the peripheral versus respiratory symptoms. So we can help identify, is it a left-sided versus a right-sided heart failure kind of presentation. Another simple diagnostic exam that can be done early on for screening is a B-type BNP lab test. This is a lab that should be negative in patients. So it's usually, I think the reference range is less than 100. If it's less than 100, that's totally fine. That's a normal BNP level. If it's greater than 100, that's highly indicative of a heart failure exacerbation. So their symptoms have gotten worse. This is a enzyme that's released when there's increased ventricular pressure and stretching on the myocardium. So that's a lab test that can be done. Imaging can be done as well. So these patients are most likely going to have an echocardiogram done, which is an ultrasound of the heart. And the technician who's doing that ultrasound is going to look for the dilation of the ventricles in the heart and also for the backup of fluid into the pulmonary system. So we'll be able to visualize that during that ultrasound. In very, very extreme cases, there can be EKG changes, specifically at the ST segment, so part of that QRS, the end of the QRS complex, the big wave on an EKG. But that's for very, very advanced, severe myocardial dysfunction. So patients who have a very stretched out heart. So when we look at this picture of systolic heart failure, you can see how the myocardial wall is really, really thin. This is a patient who definitely has increased ventricular pressure, so their BNP will be elevated. They're probably also going to have ST changes because electricity is not going to conduct through this thin myocardial tissue the same way it would through like a normal heart. These patients are going to be on a lot of medications. And I mean, a lot of cardiac medications, at least like 5 to 9 cardiac medications. And they're going to be getting them twice, 3 times a day. So a lot of medication therapy associated with managing heart failure. There's 3 big categories of drugs that are given that if you see these on a med list, you can pretty reasonably assume that this patient does have a history of heart failure and is trying to manage it. So the first one is contractility. So patients are going to be on beta blockers because these are going to try and increase the amount of contractility in the ventricles to improve that cardiac output. So addressing kind of the etiology of the problem. Anytime we're giving beta blockers, we do need to watch out for the difference between heart rate and blood pressure, because beta blockers are really given to manipulate heart. They're going to manipulate heart rate and contractility, but the side effect is hypotension. So we want to look out for that. Speaking of hypotension, these patients are going to be getting diuretics because a lot of our symptom presentation is about fluid volume excess. We have a backing up of fluid into interstitial spaces, either into circulation or into the respiratory system, depending on which side of the heart is failing. So whenever we're giving diuretics in patients, we always want to be looking out for giving too much, like overdose of diuretics, which would be dehydration. Fair? If patients are getting dehydrated, then we need to be super, super careful of them becoming orthostatic and starting to get the symptoms, the risk factors and symptoms of orthostasis. So be super, super careful looking out for low blood pressures associated with dehydration and diuretic use. Also, like we learned about in lab with giving Lasix, some diuretics are electrolyte sparing, like potassium sparing, some are not. So always be checking your electrolytes whenever you're giving diuretics on a patient, just to make sure we haven't helped them to eliminate too many from their circulatory system and caused an electrolyte abnormality. Other big thing with diuretics and these low blood pressures, we're potentially getting a low blood pressure from beta blockers, diuretics. The kidneys, always, 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 always watch out for the kidneys because they are super sensitive to changes in blood pressure. So we always need to be keeping an eye on them as well. And then finally, directly managing blood pressure. So these patients will probably be on ACE inhibitors. And we do want to be careful of that because depending on their volume status, their blood pressure can be very labile, meaning it fluctuates quite a bit. This is a big problem when patients are in exacerbation of heart failure or like acute decompensated heart failure. So acute equals exacerbation, decompensated meaning they've got symptoms. of that disease. So we do want to watch out for those blood pressure changes, especially when patients are experiencing that kind of acute presentation or decompensation associated with their disease. On the nursing side, we've got a lot of actual and a lot of risk for problems that we're going to be kind of focusing in on. So for actual problems, we can see things like activity intolerance, especially with left-sided heart failure. As fluid backs up into the lungs, people are not as capable of doing gas exchange and kind of getting around if they're short of breath all the time. Disturbed body image. So this is really about people who are not comfortable with the way that their body is looking compared to normal. And when patients develop an exacerbation of, say, right-sided heart failure and their edema in their legs gets really large, it can definitely lead to a disturbed body image. And then excess fluid volume. So this is kind of addressing the etiology of the disease. Most of our symptoms are, again, focused on volume status. So volume overload kind of produces an exacerbation of heart failure. On the risk management side, patients are at risk for fluid volume imbalance if they're not an exacerbation. So if they just have a chronic disease, they're at risk for becoming fluid volume excess. Ineffective tissue perfusion as a direct result of the edema that they may have. So we need to keep an eye on their skin and their pulses to make sure they're adequately circulating their distal extremities. And then risk for ineffective activity planning. We tend to see this quite a bit with left-sided heart failure because patients are going to have breathing difficulties. So we do want to make sure that they're planning what activity they need to take care of. Like if you're in the hospital and your patient's going to be completing their ADLs, have we provided a place for them to rest midway through their ADL so they can catch their breath? Because we can anticipate that with activity, they're going to have an increase in shortness of breath. So when we look at the solutions that we need to generate, so how are we going to help these people out? First thing we need to figure out is if they're in an exacerbation or if this is chronic disease. Chronic disease, we're most likely going to be seeing in the outpatient setting. Exacerbations or acute disease, especially decompensated disease, we're going to be seeing in the hospital. So with exacerbations, why are they exacerbating? Now, are they having a cardiomyopathy where they have an acute decrease in their cardiac output, which makes their ability to handle the fluid volume in circulation kind of decreased? So it's almost like getting an acute volume increase kind of presentation. Or is it a fluid volume status problem, like they've consumed too much fluids or been given too many fluids when they sought healthcare, like in a hospital setting? So we always want to be assessing, is it a heart problem, like the heart's getting worse? Or is it a fluid volume status problem, either from fluid that they've consumed or fluid that we have given them? Especially IV fluids are things that we need to look out for in the hospital setting. For chronic patients, or when we get through the acute exacerbation phase and are looking to get back to that baseline level of disease, then we're kind of back in the chronic management. When we talk about chronic management, a big way that we monitor whether patients are getting worse or staying stable in their heart failure is through weight management. So we want to be weighing our patients every day because we know that 1 liter of fluid is 1 kilo of weight. So we do want to be trying to figure out what their baseline weight is, or their dry weight, so to speak. Dry weight just refers to kind of their weight when they're not in a fluid volume excess or in a heart failure exacerbation. So we want to trend those weights to make sure that the other therapies that we're prescribing are effective. Things like diuretics or some of our blood pressure altering medications, that the kidneys are still able to keep up with filtering out fluid at an adequate rate. Other things we want to counsel and kind of get ready for patients in planning their care is nutrition therapy, because these patients are going to be on food and fluid restrictions. Food restrictions in that we can anticipate salt is not going to be their friend because fluid follows salt. So if they eat salty, high salt diets, they're going to have a lot of fluid retention. Fluids, because fluids are fluids. If you drink too much of them, you're going to have too much in your system. So it's not uncommon that these types of patients are going to be on what we call a fluid restriction, which is the 24-hour total volume of fluid they're allowed to consume. A couple of the most common ones that you'll see in practice are like a 1.5 liter fluid restriction, so they can only have 1.5 liters of fluid in a 24-hour cycle, or like a 2-liter fluid restriction, so a little bit more fluid over 24 hours. So actions, the stuff that we are going to be doing. There is a lot of independent interventions that we're going to be doing to manage heart failure patients. So first, around activity. So we're going to be doing fall risk assessments on these patients. We know that we're giving a lot of medications that can artificially lower their blood pressure and push them into that kind of presentation of orthostasis. It can be actual, can be subjective, so it can be objective or subjective. Whether we've actually lowered their blood pressure too much, or we've acutely dehydrated them so that they have a low blood pressure right now. So we always want to be careful. These are high fall risk patients. We want to go slow with mobility, and we want to help get them up and out of bed. If your patient says they're okay, they can transfer on their own, I would not necessarily trust that 100%. I would keep a close eye on them until they can prove that they're able to do those transferring activities on their own. Next is volume status assessments. So the first thing we want to be assessing is their vital signs. Blood pressure, heart rate. We want to look out for that inverse relationship. So blood pressure goes down, heart rate goes up. That indicates that the patient could be getting hypovolemic, so too little circulating volume. That would be a big symptom of overdiuresis or overdose of therapy. So we want to look out for that. That's also going to lead to their fall risk trouble. So we definitely want to be watching out for their vital signs. Another big one is their daily weight. For heart failure patients, daily weighing is like another vital sign. We just check it every single day for these patients. We want to start by getting their baseline weight when they first come into a facility seeking healthcare, because then we need to figure out if they're in exacerbation, we're anticipating their weight's going to go down from that baseline or that first weight. If we're in an outpatient setting where patients are not in exacerbation, then we may be at their dry weight. So we know what our target is and can easily recognize when they're in acute decompensated, so they're symptomatic and in exacerbation, versus whether they're stable. And then edema. It's an easy way to assess volume status. Look for the symptoms of fluid volume excess. For right-sided heart failure, we're going to see peripheral edema, so in the lower extremities. For left-sided heart failure, we're going to see respiratory symptoms and right-sided symptoms. So we're going to see the lungs and the legs filling with fluid. So we want to be assessing for that as well. For teaching, it's the same. So acute management is the same as outpatient management. We want to be teaching them how to manage this disease long-term. So how to recognize changes in their weight, because we know that in the hospital, that's one of our big tools for determining whether we're making progress in therapy, is are they losing weight so that their heart can handle the amount of circulatory volume that they have in their body. Same thing in the outpatient setting. We want to teach patients to do their own daily weights. So key things that they want to be looking out for. If they're gaining more than 3 pounds in a couple days, or more than 5 pounds per week, let's convert this to fluids. 3 liters of fluid over 2 days, or 5 liters of fluid per week. This is bad, right? They are going towards exacerbation. We also want to teach them about low sodium diets. Oftentimes we'll teach them about the DASH diet as well. Again, going back to the hypertension thing, we want to limit salt intake so that we can prevent that retention of fluid. And then self-assessment for edema. So how to check their own legs for edema and how to measure that edema so they can tell if they're getting a fluid volume excess by the increase in the amount of edema that they have. For evaluation, again, looking at this by exacerbation versus chronic. For exacerbation, we're looking for a relief of symptoms. If it's left-sided heart failure, we want to look for a return to normal oxygen levels and decreased subjective shortness of breath. So they should be breathing better, feeling better. And also their baseline weight. We want to trend that so that we're getting closer to figuring out what their dry weight is, or at least seeing the decrease in the amount from their weight when they first presented to a care facility. For chronic disease patients, so like primary care setting, We want to see the maintenance of their weight. So we want to assess how they're measuring their weight and how they're recording that, so that make sure that we have accurate data that they're collecting on their weights, so that we can show that they're managing their disease. And then ADL tolerance. Are they able to continue being as active as they were previously? So they're not in exacerbation, they're not losing function because of the symptoms and the fluid volume excess that they're experiencing. So those are kind of the big things we want to be evaluating for. And that's all we've got for heart failure, guys.